the Eisenhower period over in the interior, there was a feeling that you ought to terminate that and make Indians just ordinary citizens with no special relationships, sort of disregarding the treaty obligations which you had undertaken.
The evidence was clear that the public, once they understood what the dreaded termination policies were all about and how Indians traded, rural poverty for urban poverty, that it was time that a new and more constructive Indian policy be established.
Indian self-determination came in the right time. It gave people choices. It spoke to those Republicans, for example, who wanted to reform some programs. And I think it spoke to Democrats who said, we want to deliver better services here. Let's let the tribes do it.
Visiting the Kanetechapi Indian Clinic over at the Public Health Hospital, I met Bernie Whitebear, and he had a huge influence on me, just his personality and his gentleness, but his vision. He showed me around, and of course it was a terrible place physically, a dump.
Nixon's college football coach was a fellow named Wallace Chief Newman, an Indian that he was very proud of, that always told Nixon, never give up, always get in there and keep on fighting.
At that point in the game, as you know, Bobby Kennedy had been assassinated. Teddy Kennedy had taken over the Indian education issue at the old Education Labor Committee in the Senate. And Senator Fannin said, well, I've got all these other LAs, legislative assistants, doing things. I want you to take care of the Indian education issue. So I went to work on that issue, and that's how I got involved.
I worked for a young, rising House member on the House side, Al Ullman. And on the Senate side, I secured an assignment with Senator George McGovern.
It took all of about 1 minute for Jackson to agree in principle, but he wasn't going to get into the details of it. He knew it was a complicated problem. So I went over and had made an appointment and saw Forrest over in the Senate office building.
I took on the task of handling their congressional liaison, and this sort of fueled a real interest in my part on how government actually operated.
I met Forrest, and there with him was Emory Johnson, head of the Indian Health Service, who I hadn't met before, and they sat there, and I said, well, hi, Senator Jackson says we can have some legislation for urban Indians. And I remember Forrest just smiled gently, and he said, yeah.
Mel was urged to raise a question at the appropriate time, namely, Senator Kennedy, would you be willing to forego jurisdiction over the Indian Health Care Act so that we may see it enacted into law? And amazingly, he agreed to do that.
When Forrest came to me and said, have I got a plan for you on Indian health care? I sat back and said, okay. And then he said, it's going to cost $1.6 billion.
So the bill came to the White House actually with a opposition from Health and Human Services and from Office of Management and Budget. And OMB was recommending a veto.
One of the committee staffers came around to us and he put his head between Forrest and myself and says, don't you understand? You have the votes. Shut up. And it was done in 15 minutes.
Welcome to our show, Living History, a conversation about American Indian policy. I'm your host, Mark Trahant. I'm editor of the Seattle PI's editorial page and a member of the Shoshone-Bannock Tribe of Idaho. We've assembled a remarkable group of men whose vision and dedication to public service changed this country for the better. I'll start with some history. The United States policy toward Native people went from extermination to a political wardship embodied by the idea of a great white father in Washington. Through the years, this uncertainty was reflected in unsettled policy. In the 1950s, the federal government decided that it was time to get out of the Indian business. Part of that plan was moving American Indians off of reservations and into cities like Seattle. The idea called for the termination of tribal governments and to sell off the natural resources and other assets and basically and the promises made in the treaties. That is where our story begins. We're joined in a conversation with men of vision who drafted a new policy, one that was both compassionate and effective. 30 years ago, Democrats and Republicans worked together to enact the Indian Health Care Improvement Act. Our conversation looks at how that innovative policy was crafted and shepherded through the political process. Our first guest is Abe Bergman, a Seattle pediatrician. Dr. Bergman is the author of A Political History of the Indian Health Service and has been involved in public policy issues and health for 4 decades. He recently retired as the chief of pediatrics at Harborview Medical Center so he could devote full time to improving health and early learning services for children in the foster care system. Welcome, Dr. Bergman.
Thanks.
Let's start with how you got into this discussion about Indian policy and health.
Well, throughout my pediatric career, I've always been in main focus is on serving the underserved children. I worked at Children's Hospital for 20 years and then over at Harborview for another 22 or 3 years. And in the late 60s, it was obvious that some of the most underserved children in Seattle area were Indian children. And I came to know a remarkable leader, Bernie Whitebear, who had founded the Seattle Indian Clinic. I talked to Bernie and he pointed out, he educated me that the Indian Health Service did not provide any help for urban Indians, even though half the Indians in the United States live off of reservations. I had previously been involved in legislation to create the National Health Service Corps and with Senators Magnuson and Jackson. Based on the conversation with Bernie, I asked Senator Jackson, do you know that Indians living in urban areas are not covered by the Indian Health Service? He said, yes, I know. And I said, would you be interested in legislation that expanded the Indian Health Service responsibility to urban Indians? And he said, well, that sounds like a good idea. Sure, he said, but go talk to Forrest Gerard about the details. And so I made an appointment to see Forrest and walked in to see Forrest, and the legendary director of the Indian Health Service, Emory Johnson, was there. I enthusiastically said, Senator Jackson says that we can draft legislation for urban Indians to get IHS care. And Forrest smiled and said, well, Abe, he said, that sounds great, but if you do it that way, it doesn't have a chance of passage. But what about considering expanding and providing improved health services for all Indians in the United States? And that started the ball rolling, and I became educated by Forrest Gerard and Emory Johnson, and that then the process led to the creation of the Indian Health Care Improvement Act.
Senator Jackson's involvement came at an important time in Indian political history, and for that, let's broaden the conversation. Brad Patterson started working in the White House during the Eisenhower administration. He was often the point person on Indian affairs during the Nixon and Ford presidencies. Brad is a well-known scholar of the American presidency. Welcome, Brad.
Thank you.
Brad, before there could have been an Indian Health Care Improvement Act, there had to be an end to the ghost of termination. Why, first of all, was President Nixon interested in Indian affairs?
President Nixon, as a young man, namely at Whittier College in California, went out for the football team and found himself under the tutelage of a coach for football there, who was an American Indian, whose name was Wallace Chief Newman, as was named. And in Nixon's own words, Wally Newman made sure, coached me always, determined me to always get in there, never stop fighting, never give up, never side eye, keep at it. And Nixon then added, next to my father, Wally Chief Newman was the most influential man in my life. So in a way, Mark, we had a president, who was President of the United States, who way down deep had a sympathy for and interest in Native American affairs. And therefore he was very receptive when in 1969, Leonard Garment, who had joined his staff at the time, and then I had joined helping Leonard, came forward with some recommendations for a new approach for American Indians. And then a memo came to us from John Ehrlichman saying, members of the White House staff, what ideas do you have to propose for new Nixon policy initiatives in 1970? And Garment looked at me, and I looked at Garment, and we said, Indians, and went to Ehrlichman with that recommendation. And John Ehrlichman said, that's right, went to the President, and the President said, that's right. And Ehrlichman turned to us and said, you're on, and you, Garment and Patterson, have the responsibility for doing the research and development of that policy initiative. And we worked hard on this. We consulted with Indian people, Indian tribal governments. We consulted with Indian scholars. And the message came out in July 8th, 1970. Let me read just the first two sentences. Said Nixon to the Congress, the first Americans, the Indians, are the most deprived and most isolated minority group in our nation on virtually every scale of measurement: employment, income, education, health. The condition of Indian people ranks at the bottom. And he went on to recommend a series of new initiatives, particularly the overturning of the termination philosophy, which had come actually from the first Hoover Commission and also was embodied in a concurrent resolution of the House of Representatives in August of '53, concurrent resolution number 108, which would have destroyed the Indian tribal government, in effect destroyed the treaty relationships protecting their lands, and actually happened to more than one Indian tribe. One in particular I'm thinking of, the Menominee tribe of Wisconsin, who all the tribal land was gone. It was given over to private development and sold. The banks took over Indian tribal currency, the finances, and it was a disaster for Indian people. And Mr. Nixon resolved to change that. And so the most prominent recommendation in his message was that we should have self-determination rather than termination. We should have a new Assistant Secretary of Indian Affairs. We should have economic development for Indian people. We should have legislation which turns over the functions having been performed earlier by the bureaucracy and the BIA to Indian tribes themselves, to Indian tribal government, law enforcement, education, social development, economic development, and so forth, with the BIA money going with it. But the functioning would be to build a strengthened tribal government and get them into running their own affairs. And that legislation then was introduced on the 8th of July in 1970 to the Congress, and then it got into the hands of some remarkably expert and dedicated people on the Hill who helped push that legislation through to almost all of it was accepted and enacted by the Congress.
So that sets the stage. After dealing with self-determination, the next one up was Indian health care. And here we have a White House who's interested. We have things in Seattle dredging up information that made the case. What was kind of the climate before it went to Congress? Either one of you might.
Well, as Nixon said in his message, Indian health was in terrible condition. And Abe, you've done the research, and we're in the middle of that situation here in Seattle.
Yeah, but I think in Congress there was indifference. It wasn't a big issue at all. And even in the health field, very few people really were concerned about Native Americans.
Well, again, we'll broaden the conversation by talking to people who are working with the Congress. Forrest Gerard has had a remarkable career. He is a member of Montana's Blackfeet tribe. He was the first Native American professional staff member on the Senate's Interior and Insular Affairs Committee, working directly for Chairman Senator Henry Jackson. Welcome, Forrest. And Rick Lavis is currently the Executive Vice President of the Arizona Cotton Growers Association. He worked for Arizona Senator Paul Fannin, a conservative Republican, and was instrumental in the enactment of the Indian Health Care and Improvement Act. Welcome, Rick. We had just heard Dr. Bergman about talking with the Jackson folks about some piece of legislation. The White House had passed or sent a message to Congress in 1970, so the climate had changed. Let's pick up the story from the legislative side. Maybe start with Forrest.
I would like to just make a couple of points about the message. I think it's fair to say that there was a high degree of skepticism among the tribal leaders because rightfully or wrongfully the Republicans had been accused of fostering termination during the 1950s. So not every tribal leader really received it with open arms. Also, when I joined the committee in 1971 and inquired about the status of the legislative package that had been sent forward, senior staff told me that some of the old bull Republicans, as they characterized them, were not exactly enamored that Nixon had sent that message forward, because they were still ardent supporters of the termination policies. And the names that were mentioned to me were Gordon Allott, who was ranking minority on the committee, Carl Munt, powerful senator from South Dakota, and a Senator Curtis, I believe, from Nebraska.
How did the health care issue surface with the Indian Health Care Improvement Act?
Well, the legislation was introduced into the committee as a courtesy on the part of the chairman and the ranking minority. It was my understanding on any legislative proposal sent forth by the administration, Chairman Jackson and minority ranking Gordon Allott did that as a service. And there was no effort made to move the legislation that languished there. So then we had this effort and drive for Senator Jackson to begin developing an interest in the nomination for presidency. And I like to think what occurred here was a convergence of two interests. One, the White House wanting to change basic Indian policy with a more constructive and enlightened approach. And secondly, the interest of a powerful committee chairman in the nomination for presidency of the United States. So with that vacuum, so to speak, and no action on the legislation, my proposal to the Jackson people and the senator himself, why don't we pick up the administration's package to develop the policy of Indian self-determination and move forward with that. We were fortunate in that the ranking minority on the committee, Senator Fannin, had on his staff a gentleman by the name of Rick Lavis, who worked closely and very hard all through that entire process.
What was your view from that side when you first heard about this proposal?
Well, you always got to remember when Forrest came to me and said, I'm going to need some help and on Indian health care, and I says, well, okay, so they laid out the case for it, and it was compelling in many ways. And then I asked the typical Republican question, is how much it's going to cost? He said, oh, $1.6 billion. And I took a deep breath, and I said, okay, let me ask the senator what he wants to do here. And I went to see Senator Fannin, and here was the interesting thing. The Republican leadership had changed. Senator Allott was defeated in 1972. Senator Fannin became the ranking member. His experience as governor in Arizona, his experience on Indian education issues, particularly Bobby Kennedy in the late 60s, I think brought him a better view about the needs for Indian communities. And I said to him, okay, here's a bill. It's comprehensive. It takes in all the aspects of Indian health care. And the facts are very clear. This is a very deficient operation. We're not providing the kind of care and the facilities we need. It's going to cost $1.6 billion over 7 years. And he just looked at me, and this is always interesting to me because it was so quick. Here's a conservative Republican who I thought would blanch at this. He said, Rick, we got to get him healthy. End of story. Go get it done.
I would add just one thing, that the original Nixon message 6 years earlier had strong recommendations for increased and better services to urban Indians and much better services on Indian health. But it was the legislation that you worked on some years later that brought that to fruition.
Mark, I'd like to emphasize one point about the legislation. The way we developed the authorization was along these lines. We laid out the cost in each of the major program areas and titles on an annual basis. But in addition to that, in order to give the agency sufficient funds to really attack the backlog of problems that they were faced with, we added another dimension to it, so to speak. and authorized an additional appropriation for each of the 7-year period that would supplement the regular appropriation and not supplant it. And by stretching that over 7 years, it made it a more reasonable period of time for the Indian Health Service to manage that sum of money. If we'd have dumped $1.6 billion in a 1-year period of time, they could have never handled it.
I just want to ask before we switch to another segment, after having this idea of improving urban health, Indian health, how did it look to you after the legislation went through the grinder?
It was a crowning achievement. I think that students of political science should read that bill, because one of the things that Forrest and Rick crafted, which is unique, is the purpose of legislation, which was, there's a preamble to the bill, which rarely occurs. So there's no question about what Congress had in mind. And then the comprehensive nature of it. So I think it was a huge accomplishment.
I think Forrest and I are very proud of that report, because one thing it does, I mean, in addition to laying out the program, it is a comprehensive review of the deficiency of the Indian healthcare system. And we detailed everyone from manpower to facilities to services, and that one report just stands there as a clear example of why we do that kind of legislation.
The bill then came to the White House, and we found that it was opposed by the Secretary of HEW, Mr. Weinberger, and opposed by the Office of Management and Budget, who recommended a veto. I think they were probably scared off by the $1.6 billion.
Sure.
And then a gentleman named Ted Mars and myself were in the White House at the time, and we countered that argument to Mr. Ford, and we won out the argument, and Mr. Ford signed the bill on the 30th of September, 1976.
Very good. Forrest, you've told me before about a book, How Our Laws Are Made, and that's a pretty antiseptic approach. In real life, it must have worked very differently.
That's true, and I don't want to oversimplify a highly complicated process called the legislative process. But the book was a little pamphlet actually produced by the Congress for citizen consumption, to sort of an overview, if you will, on how laws are actually made. And I've often made the point in legislative discussions with my tribal clients that if you can read the English language and comprehend it, you can understand the process. However, where the complication sets in the legislative process, you need human beings to feel it. And this is where personalities, ideological differences, all of these factors that are prevalent in the United States Congress come into play.
Well, one of those complications is which committee gets jurisdiction over the bill.
True.
In the Indian Health Care Improvement Act, the House of Representatives had 4 different committees looking at it.
Well, it was referred from the Senate. It got 4 referrals, 1 to the Interior Committee, 1 to their Ways and Means because of the Medicare issue, 1 to Foreign Trade and Commerce for some strange reason, and they all had to report back to the House their conclusions. And House Interior Committee had really no problems with the bill. House Ways and Means Committee had no problem with the Medicare, Medicaid provisions, but the Commerce Committee did, and there is where they cut the bill. They cut the level of authorizations considerably, but in terms of dealing with it, and that for both Forrest and I, we had to deal with all 4 kind of committee, all 3 basic committees. For my part, I went to John Rhodes, who was I believe at the time the ranking member, matter of fact, he'd been the minority leader of the United States Senate, of the U.S. House of Representatives, excuse me. And I asked him if he would not support the bill, and he did, and he went and testified for it. So that made it very helpful in terms of having the leading Republican in the House involved in this legislation.
How did you avoid that many committees in the Senate?
Well, there were only 2 that were really in line to claim jurisdiction on it. One was the Labor, Health, and Education, chaired by Senator Kennedy. And we helped arrange a Indian meeting over in the Senate with the National Indian Health Board being involved. And a young tribal member from Yakima by the name of Mal Sampson was very active in the Indian Health Board. Senator Kennedy agreed to appear in person, and after he made a few short remarks, he opened himself up to Q&As. And Mal Sampson asked the senator if he would be willing to forego the committee's jurisdiction on the bill in order to expedite its passage. And I think much to the disappointment of the senator's committee staff, he agreed to do that. However, there were some trade-offs for it in that the people in the Kennedy staff were interested in some mental health provisions, and we accommodated them by amending the bill further to include mental health provisions for Indian people in the bill that was pending.
Well, actually, there would have been a third committee who could have laid claim. It would be the Senate Finance Committee on the Medicare. But we went down, and it was really right around the hall from us. We went down the hallway and said to their staff people, here's what we want to do. Do you have any problems with this? And help us with the language. They gave us a language, they gave us our blessing, and they said, we're not going to stand in your way. You can put it in your bill, and when we come to the floor, we'll say we'll give our blessings. So we avoided the jurisdictional question there just by immediately going to the staff and saying, here's what we want to do. And they were very helpful to us. I mean, they bent over backwards to give us the right language and the right provisions. It wasn't just a pro forma thing for them. They actually helped us write that language.
And what essentially that did was to make the IHS facilities and those run by the tribes eligible for Medicare and Medicaid reimbursement. Several years later, Dr. Johnson told me that this had been a real windfall for the tribes because many of the Indians were eligible for one or the other services. And it got to the level of income that OMB was trying to figure out a way if they couldn't deduct that amount from the Indian health appropriation, but the committees would not go along with that.
Mark, if I can put my political science hat on for a minute, just think 30 years ago on this particular piece of legislation, Indian Health and Care Improvement Act, a Republican, a Democrat, an Independent all reached out across party lines and with collaboration and cooperation got this legislation passed. I think now the Congress today and the partisanship in Washington would that we could recapture that same kind of collaboration in our government today. It would. I wish we could.
Yeah.
Speaking of the collaboration, particularly between the Congress and the White House, you had a checklist that you were working off on the bill.
Yes. When we started out, I put down every step that I could conceivably think of how to make this, how the bill gets passed, and all the steps I kept checking it off against. Well, I got to talk to this chairman, got to talk to this member, got to do this, got to do that. You know, from my side, Forrest had sort of a different, he had a list, probably wasn't written down, but at the very end of my list, if you're asking this question, what's the end of the line? The end of the line was Senator Fannin was supposed to call the President of the United States and said, sign this bill. And so the bill was down to the White House, and I went on the Senate floor and I said, Senator, it's your turn. You need to call President Ford and tell him you want to sign in the health care bill. He says, and my list says, this is what he does. Everybody else does it. And he said, I'm not going to do it. So wait a minute, it's on the list. My list, not his list. But he represented the old school of separation of powers, and people understand this when they do this process. I mean, you bring all these personalities to bear, as Forrest talked about. Here's a situation where Senator Fannin took it very seriously his role as a legislator. He had done his job. He sent it to the White House. The president's job was to sign it or veto it, as the case may be. And if he wants to talk to me, he said to me, he'll call me. Well, luckily he signed the bill. We didn't have to make the call. But it was sort of that lesson. If you're in this process, you really never know sometimes what lies around the corner, no matter how prepared you may be.
Maybe it wasn't luck.
Our staff job was to lay out for the president the pros and cons. HEW has a memorandum giving its views. OMB has a memorandum, and that comes to, in this case, our desk. And we have a final memorandum to the president, but laying out the opposition and the reasons and are countering to that. So that's good staff work for the president, which is our obligation, just as it's your obligation from where you're sitting.
I think another thing, Mark, that was in the background is there was an ample body of evidence on the substandard health status of American Indians that flowed generally from their poverty conditions. The public had some sensitivity to that, and maybe an uninitiated or uninformed staffer for a senator was satisfied that this bill was intended to help overcome some of those health deficiencies.
Our last guest is Ralph Forcara. He is Executive Director of the Seattle Indian Health Board and an enrolled member of the Juan Yeno Band of Mission Indians from San Juan Capistrano, California. Welcome, Ralph.
Thank you.
30 years later, how has this act, what has it meant for people who get services from the Seattle Indian Health Board?
Well, I think there's been marked improvement in healthcare delivery for Native people, and certainly the idea of tribal governments taking over more control of the healthcare of Indian people has improved quite dramatically. I also think that there's been elements of the bill that have not been enacted in the fashion that they needed to be enacted, and have not really progressed in the to the level that I would hope that they would have evolved. On the urban Indian side, of course, we've had struggles trying to just maintain our recognition and our identity, and as a result of that, have had difficulty getting appropriate resources to continue the work that we do. Some of us that have been fortunate enough to work in areas where there's been a lot more cooperation, such as us here in Seattle and in San Francisco and some of the other metropolitan areas where there's a greater understanding of cultural differences and acceptance of that, there seems to have been a much stronger development. But certainly the struggle of Indian people, and certainly the extent of health disparity that exists among Indian people, both on and off reservation, continues. And so while I think the Indian Healthcare Improvement Act has set a course that I think is an extremely positive course, I don't believe that we've realized the benefits of that course, partially because of financing and the mechanisms associated with that, and partially because I believe that this is a very challenging and very difficult pursuit. To change people's behavior, to change people's health, is not something that can just be geared to healthcare. It's got to be a community effort. It's got to be an effort on the part of really a partnership between the community and the institutions that are providing resources and services to that community. And I think that's the beauty of the Indian Healthcare Improvement Act, and especially the idea of Indian self-determination.
In transforming Indian policy to self-determination and strengthening Indian tribal government, one of the implications, one of the assumptions really made all the time is do we have better public administration within Indian tribal government? Do we have men and women who are better on accounting and budget and finance and management and organization? And I'm sort of hoping that's been the case as one of the prerequisites and one of the results of the policy of self-determination. How is it in Seattle? And I'd be interested in Rick and Forrest commenting whether they've observed that kind of improvement in the administration and management of Indian tribal organizations.
Well, from my point of view, I think that there has been an improvement in the management. Partially, I think that there is an effort on the part of the Native communities themselves to be more accountable to themselves, and to be more accountable means putting in accountabilities and systems that will allow you to use your resources most effectively. And in that regard, I think we've done a fairly remarkable job. There are certainly exceptions to that. Just like with any institution, there are some that do better than others. It means, though, that I think that they're training more Indian people in fields like management and accounting and business, and as well as the health professional areas. And I believe that combination of having opportunity and accepting responsibility and trying to find ways of exercising that responsibility, the whole idea of self-determination, I believe is in fact happening. It's happening possibly at a slower pace than we would like it to. But I certainly see great progress going on in both the reservation and the urban communities.
I'd like to speak to that. First of all, I would comment on more of a global basis. Because of the nature of Indian affairs and tribes being placed on unproductive lands, they really had no experience in managing large sums of money, save for those tribes who perhaps not intentionally were placed in an area where they had valuable natural resources, oil and gas, timber, and so on. So those tribes did have the benefit of managing some of their income for various purposes. Therefore, the federal government, through the Bureau of Indian Affairs, really served as a surrogate government for Indian reservations, because they operated the agencies that doled out welfare funds, managed the natural resources, managed the health care
They ran things.
operation. They were the show on the reservation. What the Nixon self-determination policy did was to say, Indian tribe, you have the right to assume the control and responsibility of programs and services operated by the Bureau of Indian Affairs and then the Indian Health Service on your reservation. And the secretary, here is an important provision in the Indian Self-Determination Act. The act was framed in such a way that the secretaries for Interior and HEW were directed to honor these requests for the tribe to take over. Now, there was a declination process, but the burden was on the federal government to prove that a tribe was unprepared to handle and manage these funds.
In my time in Washington, my sense about Indian self-determination was that there was a cadre of people who had become adept at managing these kinds of programs and institutions. They were out of the poverty wars, so to speak, yes. the training there. Many of them were trained in the Indian desks throughout government. There are many new initiatives in colleges and universities to train Indian personnel and administrators. I think they had all an impact in terms of strengthening many tribal governments. My impression now is, and I say this just off the top of my head, I don't think the federal government is doing a good enough job at this point of encouraging or encouraging that process now. I think they need to spend more time to internally. I think they've let the self-determination approach just become another program. And it really is the essence of the Indian self-determination policy that Mr. Nixon talked about and that Forrest and I have attempted to do in the two pieces of legislation we were working on, plus all the other initiatives and stuff that he was doing. But for my purpose, for my viewpoint, I think they've let that approach go and not strengthen it. And I think the tribal communities ought to say, okay, let's take another look here. Let's renew our compact with the federal government over this thing, and let's do more to encourage it.
I wonder if one of the obstacles to doing more is 30 years ago, you had a vision for a new way of doing things and set out a plan and a way to do it. Now, it seems like programs like Indian Healthcare Improvement Act, and particularly urban Indian health programs, the fight is over saving what you have. In this latest round, the administration proposed to zero it out, and Ralph, take it from there.
Well, I think you're right, Mark. I think that there's still the struggle of exercising self-determination, because one of the unfortunate consequences of the self-determination policy is that's only a policy. Without the resources to implement that policy, there's not an awful lot that you can do. And unfortunately, while there's a lot of talk about the wealth that's coming into Indian communities as a result of gaming and other things, that's still just a very, very small segment of the native population that has access to those resources.
There are many tribes up in the northern plains and elsewhere who really can't make money on gaming because there's no market there. But you have that sense that, gee, Indians are wealthy now. Why should we have to help them again through tax dollars? There's another thing going on here as well, and that the tribes who have made a lot of money in Indian gaming, they want to become players in the political process. And they are willing to lay out big fees for high-priced lobbyists and lawyers in Washington, D.C., so that they're able to fight their battles. I think we always speak of an even turf. Well, they're able to even the turf up because they have money to hire the right kind of Washington, D.C. representatives. But the rest of the tribes are caught in sort of a no man's land on lobbying. They don't have the muscle to increase budgets. They have to rely on friends in the Congress and elsewhere. So somehow or other, we've got to develop a stronger cadre of Indian people who are knowledgeable on the processes for policy and budgeting and are able to make the case before the committees of Congress. Nothing has changed there. The budget process is the same as it was 30 years ago when the three of us were fighting the battles.
I think the problem is, not a problem, it's just things have changed. You had, as I said, a harmonic convergence. You had all these things coming together at the right time to get the Indian health care improvement passed. Those are rare occasions. They're still doable. But you have to find new champions, you have to find new staffers, you have to find people committed. And I think right now there's has been, in my opinion, since '76 or maybe later, a sort of lull in that policy. Maybe you call it policy exhaustion. Okay, we've done all this work. Forrest went down to the Department of Interior was 77?
So, yes.
And so we started another major effort to reform the BIA. Not an easy task. I mean, I remember Forrest telling me when I walked in the door, he says, well, Rick, welcome to the BIA. We have 13 GOA audits facing us. Go fix the damn thing. I think what Indian communities have to do now is have to take a look at their political leadership, both Indian and non-Indian, in the Congress and say, well, who's out there? Who's really leading? Who's helping us? And maybe you've let that go. Maybe you haven't developed that relationship. So I think you've talked about that. And you have to come back to it, assuming you have facts on the ground. You've got problems to solve, major problems, major reforms. I suspect the BIA is still in need of some.
Very good. That's all our time. Here we are, 30 years since the enactment of the Indian Health Care Improvement Act. It's important to take a look back and understand how such an important bill became law. I'd like to thank Abe Bergman, a pediatrician whose work on the ground here in Seattle helped demonstrate the need for improving Indian health. Thanks also to Brad Patterson, who made certain that President Ford signed the Health Care Improvement Act. And thank you to Forrest Gerard and Rick Lavis. Forrest is one of the most important American Indian leaders of his generation and the author of many significant legislative accomplishments, including the Indian Health Care Improvement Act. Rick Lavis, a Republican staff member who knew that the notion of improving the health of Native Americans transcends politics. And finally, thanks to you, Ralph Focara, whose work with the Seattle Indian Health Board demonstrates the genius of this important project.
The White House role is crucial in development of new policies and crucial in the handling of crises.
The lesson here was bipartisanship, playing to win, as opposed to politics now, which is crash and burn.
If you're interested in public service, you go do it, and you learn. And the best place to learn, and I agree with Forrest about this, is the United States Congress. There is no greater place to learn about public policy making.
It pleases me to really see the array of young Indian men and women today who've specialized in Indian law, lobbying, legislative, and so on, who are working in the city representing tribes throughout the country.